Okay, so go ahead, Tanya. So you want me to choose
Okay,
this one?
so if you click on, make sure they know the website, that NCSBN website.
Okay, oh, let me go back to the other one.
Click on
Okay,
that one.
so
Okay.
NCSBN, and then I'm gonna
Okay, and
go
then you
to,
see where it says NCLEX test plan.
okay, oopsie, sorry, I was too click happy.
If you click on that, uh, no, go
Okay,
down right here. You see that lady with the glasses? Yep,
yes.
click on that one. And then you see
Mm-hmm.
it says RN. You can download it.
Mm-hmm.
And when you
Or,
download it, it tells you the content areas that you should be like practicing questions in, like what they
mm-hmm.
expecting of us. So scroll down a little bit more.
Mm-hmm.
And right about, that's introduction, keep going. Right
Mm-hmm.
here, you see where it says client needs? Go down a little bit more.
Mm-hmm.
Client judgment. So it tells you exactly what they're gonna kind of like hit on.
Mm-hmm.
And then if you go back to the book, you can click them same and just do questions like, I've been just doing like 10 questions. I'm not trying to overkill, kill it, but click on study. And then
Okay,
you see how
study.
that the website said client need. So when you
Mm-hmm.
click on client, all four of them, you could do like 10, 20 questions out of, or 50 or whatever. And then the next one was content area. If you click
Mm-hmm.
on that, and if you know you got an issue with something, you can just like click on pharmacology and you could do, you know, push begin. You got 995 questions to do. You can even skip questions if you want to, right? Push submit and now hit rationale. Yep, and it tells you why. Yes,
Mm-hmm.
and so you can skip if you come to, you can go to question 10. You can skip it, like, okay, so the first five of these, 5 or 6 of them is going to be like the same, let's say pregnancy or maternal, right? It'll be like
Mm-hmm.
that. Or diabetes, it'll be like 5 questions. And if you say, okay, well, I got enough of this, I'll move forward like 5 questions and just switch again for you.
Okay, right, because this
Mm-hmm.
is hype. Okay, and I'm gonna actually go back because after our discussions, we'll be able to do the diabetic questions actually.
You couldn't
Mm-hmm.
even do that with the other Saunders book where you would skip and just go straight to the rationale. You would have to actually answer that even in practice mode to get a
Study mode.
rationale. Yeah, that's
Okay, so
crazy.
submit. So yeah, okay, so you see the rationale. Okay,
And
so
it
that's
tells you.
good.
Mm-hmm.
Okay, awesome. Okay, and so for those that are watching the video, let me just go back to the book to so they can see what the book actually is. And that's going to be, let me make it bigger, and that's the Saunders, this book right here, the 9th edition. Okay, and so in case you don't know about the next generation NCLEX, I just want to add, because this is in my library also, this is a book that I've started to read over past couple weekends, the next generation NCLEX test items. So this really lets you break down the types of questions and how
Mhm.
to answer them so you won't be surprised. So you know, okay, I've got to click the tabs, I've got to read the nurse's notes, I've got to drag and drop, or it's a bow tie, or it's an extended select all that apply, right? That could have up to, I think, 10 choices. So if you're not familiar with that, get familiar with it so it doesn't surprise you, because your anxiety is already going to be a little elevated. So anything that you could do to keep your anxiety down, and that anticipatory guidance, right, that we always provide for our patients, that's the same kind of deal here. Okay. All right, Miss Tanya, did you want to share anything else? Because you're giving us a lot of good information right now.
I had found a couple of more stuff, but I think the most pertinent stuff is just following their plan and following the questions that they ask you. And once you know you're getting stronger with the questions, then you move on to your weak area.
Okay, yes. And I will say, I think just before you came, what one of the ladies was doing is using UWorld. And that was something that I was mentioning too, is to use UWorld, take 75 questions, or to use Kaplan, if you're a Kaplan person, take 75 questions. And then when you get the breakdown, whatever that weak area is, that's what you need to focus in on. But you may already know, man, I don't remember anything from maternal newborn. I better hit that, or pharmacology is pretty fuzzy for me. You better hit that, because pharmacology is what 12 to 15%, is actually 16% for the RNs, right? So I think it's similar for the PNs. So if you know that that's a fuzzy area for you, then you really need to work on it. And that's just another way that you could do it. Okay, I like it. Anybody else have anything to add before we jump into our review of endocrine and then our case study?
No.
All right, so in the chat, I put the link for endocrine. I like the pictorials just because I know that you all are watching videos. I know that you're reading your book. So this is maybe something that will just kind of reinforce what you're already doing, and it gives it to you in a different way. And you were like, oh yeah, I remember that. Okay, so let's go to when we think about the endocrine system, remember the endocrine glands, they secrete hormones directly into the bloodstream and they go to the target organ, right? And so we start with from top to bottom. The pituitary gland is the master gland and it secretes growth hormone, right? It also helps control the other glands. The pineal gland secretes melatonin, which deals with our sleep-wake cycle. Moving on down, we have the thyroid gland. The thyroid gland controls the metabolism. On the thyroid gland are four glands that are like grains of rice, and those are the parathyroid glands, and they help regulate the amount of calcium that's in the bloodstream, right? We have the thymus that's at the center of the chest, and that's most active in our pediatric patients because as we get older, the thymus starts to shrink. We also have the pancreas, which is, I call it double dipper because the pancreas is a part of the endocrine system because it secretes insulin and glucagon, helping to maintain our blood sugars, right? But the pancreas is also part of the digestive system. It's an accessory organ and it helps to make that bicarbonate, which actually neutralizes that acidic mixture that comes from the stomach going to the first small part of the small intestine, the duodenum, right? So we also have the adrenal glands that sit on top of the kidneys, and the adrenal glands are responsible for making our stress hormones. So the adrenal glands, which sit on top of the kidneys, I call them the party hat that sit on top of the kidneys, they are responsible for the glucocorticoids and the mineralocorticoids and our androgens. Okay, so that's the glands dealing with the adrenal glands. And man, I remember I was talking about endocrine with another group yesterday, but I did not mention the testes and the ovaries. Hopefully they remember that. Oh my goodness, I feel bad that I didn't remember that to mention. All right, well, I'm going to jump in though. I'm going to stick with the vein of the adrenal glands. And whenever we're studying, these glands, we think about these glands, they can have where they produce too little or too much of the particular hormone that they're supposed to be responsible for producing. And that could be due to maybe there's a tumor, maybe there's a trauma, maybe there's some kind of imbalance in the patient, right? So when we think about the adrenal glands, again, we think about the adrenal gland and the adrenal cortex produces glucocorticoids, which are your cortisol, your mineralocorticoids, which is aldosterone, and then sex hormones, the androgens, right? And so the adrenal medulla, which is the inner part, right, produces catecholamines, epinephrine, and norepinephrine. Okay, so when I think adrenal glands, there's the outside, that's the adrenal cortex, excuse me, and then the adrenal medulla is the inside layer. Now, when we think about a patient that has adrenocortical insufficiency, I'm showing my screen, you should see the Addison's lady, right? And so always think in terms of clinical cues. How is the patient going to present? Because NCLEX is going to want to know, do you recognize that this patient is presenting with this particular condition? So if you have a patient that comes in, she's thin, she has weight loss, anorexia, she has this bronze pigmentation, tachycardia, weakness, fatigue, hypotension and increased heart rate, right? Tachycardia, they're craving salty foods. She may suffer from hypoglycemia, hyponatremia, hyperkalemia, and hypercalcemia. Right? She can have diminished libido, emotional lability, and depression. And when we say emotional lability, she could be happy one minute and then crying the next. Okay. So this is what your Addison's disease patient looks like. They don't have enough of the adrenal corticoids. So the diagnostic procedures for this patient that we could expect is going to be serum adrenal cortical hormone levels, right? That makes sense. We have to draw those levels to see if they're within normal range. Electrolyte panels may have to be done, maybe an abdominal or renal or CT scan. Okay, so the nurse also will need to know to assess the blood pressure, the heart rhythm. Whenever we have abnormal potassium levels, that's a no-brainer, right? We have to monitor the heart rate. That's if the potassium is low, if the potassium is high, we always want to monitor the blood pressure and the heart rate. And this patient should have telemetry, right? So we also want to monitor for Addisonian crisis, okay? So it's also known as an adrenal crisis. And so what is happening with this patient in an Addisonian crisis? They have characterized by signs of shock, hypotension, tachycardia, tachypnea, and pallor, okay? And so this Addisonian crisis can be secondary to stressors such as infection, trauma, surgery, pregnancy, or emotional stress. So this patient that's in an Addisonian crisis will require IV fluid replacement and IV steroids, and they might require respiratory support. When I think about my patient that has Addison's disease or adrenocortical insufficiency, the medications I would expect to administer would be some adrenocorticoids, like your hydrocortisone or your prednisone or cortisone. And so we really have to provide emotional support to this patient and educate the patient about the need for lifelong replacement. Now, something that's important is if you have a patient that is taking corticosteroids for any reason, it's really essential that we teach them to wean themselves off. Because if the patient is taking these steroids for whatever, medical reason, and they abruptly stop taking it, they can actually have an adrenocortical insufficiency. That's really, really important to educate them about that. Now, we talked about the Addison's lady. Let's now go to my friend, Mr. Cushing's. Excuse me. So Cushing's disease or Cushing's syndrome, this patient has excess. So my lady, she had not enough. Addison, think I need to add steroids. Cushing, they have too much. The characteristics of this Cushing's patient, and this is like a very memorable kind of image, right? Upper body obesity, thin extremities, moon face, buffalo hump, neck fat, thin, fragile legs or skin and with purple striae, osteoporosis, hyperglycemia, hypernatremia, hypokalemia, and hypocalcemia. So when I think hypocalcemia, I think of two signs. Can you all tell me what those two signs are that I'm testing for?
Calcemia, hypocalcemia,
Yes.
muscle, you won't really see much activity with the muscle.
Okay, yes, two signs. They have a particular name, and I might not be asking the question properly, but when you see this, you'll be like, oh, yeah, yeah. All right, so let me bring this over real quick so you can see what I'm talking about. What's that?
Oh man, you told us that 1,000
Forgot the
times.
word for
When
that.
you when
but I
you
know what you're
twitch,
talking
the eye twitch when you hit it.
Yeah.
Oh Lord.
It
Okay, so
automatically does it by itself. They can't control it.
yeah, so that's Travasic sign, right?
Thank
Yeah, that T word.
Hypocalcemia. Yes.
Oh, Lord.
Okay. Okay, so let me go back. And so I want you to notice something about this patient. Do you notice that he has those steri strips or the strips over his neck? So that
Yeah.
tells me he probably has had his thyroid removed,
Mhm.
right? And so remember, the thyroid and the parathyroid sit on the posterior aspect of the thyroid. So any patient that has their thyroid removed, part of it, they probably are going to be at risk for low calcium, right? And so this is a test for low calcium, these two tests. So Chvosik sign. So the clinical cues could be like, okay, I'm tapping my patient on the cheek and there's a twitch, an involuntary twitch, like you see here. That tells me hypocalcemia off the bat, and that is a positive Chvosik sign. Okay,
What's the other one? I
it's
forget that.
it's coming up, and it's actually on the screen. You could see the name on the video.
Word. Huh.
Yeah, so
It was at the top too, son.
Trousseau, yes, Trousseau sign,
That
right?
one. Okay, so C matches with C, calcium matches with Chevex, and the other one is just automatically the other one in my
So
mind.
Chvosik, just remember C for cheek, okay? And so he's going to do the same thing, but I like that video because it shows both of them. And so with the Trousseau sign, the blood pressure cuff is going to start to be inflated and the hand is going to involuntarily contract. Like the patient is not doing that on his or her own. The hand is automatically doing that, and that is a positive sign for hypocalcemia, okay? So, and the reason why I wanted to show you that, because you could have a patient that presents and they're, have this corticosteroid excess. And we know with Cushing's, they're going to have hypocalcemia. So somehow, if it's like a case study, it could start branching off and it's like, okay, wow, now this patient, is showing a positive Chvosik sign. So yes, you will automatically know that their calcium is low. This is a Cushing's patient, right? Because they have corticosteroid excess. Okay, so you should be able to link all of those things together. Now, in children that have Cushing's disease, they're going to have a slower growth rate. And then in general, patients that have Cushing's, they can have a backache, bone pain, they can have tenderness, increased thirst, and urination. That makes sense because they're going to have hyperglycemia, right? So whenever I think hyperglycemia, I think polydipsia, polyuria, polyphagia, right? Again, thinking with your endocrine system, and it makes sense if the glucose levels are high. Okay. So this patient might have to have a diagnostic procedure of a nighttime salivary cortisol levels, because the high cortisol, excuse me, levels are what's causing this patient to have these issues. So with this patient, our nursing interventions are going to be to monitor this patient for infection and all the other symptoms that they have, the gynecomastia, the fluid retention, all of those things. We have to, of course, monitor those as well and treat symptoms, look for skin breakdown. Make sure the patient doesn't fall because their bones are already brittle, right? And so a lot of times, again, these disorders are caused by tumors somewhere in the endocrine system. So they may actually have to have surgery to remove the tumor if it's an operable kind of tumor, okay? Let's see. This patient should also eat foods that are high in protein and calcium. Makes sense, right? They should have low in carbohydrates. That makes sense too, because they have hyperglycemia. Foods that are low in sodium because they have sodium retention, right? And they need potassium supplementation. Well, that makes sense because they're low in potassium. So all of this, if you understand, because this could be like an extended drag and drop or an extended select all that apply, the nurse would know that the patient that has Cushing syndrome, we should do this, right? And administer potassium, administer sodium tablets. Please don't do that because that's not what you want to do. You want to do the opposite. But that's how you should start thinking, because that's how the questions could present themselves. Okay. Any questions about Addison's and Cushing's?
Addison's, the hyperglycemia is with Addison's too, right? Because they're on prednisone and you have to taper that stuff off. I know
Okay.
a lot of test questions we had about prednisone, you got to taper it instead of suddenly stopping it.
Yes, so you're kind of mixing two things together. So yes, if your patient is on prednisone, I do have to monitor their blood glucose levels, especially if they're diabetes, because it can elevate their blood glucose levels. So that is true. Now, also, if my patient is on prednisone, I should tell them to taper off. They have to wean off, like lower the dosage gradually, not just saying, boom, I'm going to stop taking it. Because if they stop taking it, what happens is it doesn't give the body enough time to say, whoa, there's not enough. I have to start ramping up my production. And then they will have an insufficiency because their adrenal glands are not making that steroid because they were actually taking it. Okay, so two separate things, but they're both connected to prednisone. So prednisone is really tricky, and I would recommend if you have the medication cards, definitely go back and look at your prednisone card because that's one that you could see for so many reasons, right? Not only in the endocrine system, but inflammatory diseases and respiratory conditions, any patient that has immune system, any inflammation, rheumatoid arthritis, you could see prednisone and it's, like medications, those corticosteroids. So that's definitely one medication class that's worth reviewing. Okay, does that clear up any question you had, say?
Yeah, I just often do. I do get them mixed up when it comes to hypo and hyperglycemia. So I just gotta, you know.
Yes. Okay, so think Addison's I have to add. I have to add the steroid, and I also have to add glucose because she's hypoglycemic. So we have to add. Her blood pressure is low, so I have to add, blood pressure. That doesn't make sense, but if you think of it that way, it might make you remember that you
Yeah.
have to add. Okay. All right, excellent. The next situation or the next conditions I want to talk about is the thyroid. So we talked about low first. So let's talk about hypothyroidism. So I really love this picture, excuse me, because it gives you a good visual of what my patient looks like. So remember, the thyroid is responsible for controlling metabolism. If the hormone that the thyroid produces is low, the patient's going to have hypothyroidism. That means things are going to start slowing down. So think about it. They're going to be tired. They're weak, increased sensitivity to cold, constipation because their GI system is slowing down, weight gain, dry, brittle skin, deepened, hoarse voice, joint pain, hyperlipidemia, and anemia, depression, menstrual disturbances. And when I think menstrual disturbances, that could come with a lot of conditions. But if a patient a lot of times has menstrual disturbances, that's the body's way of saying, look, I can't even support my own body functions, so I definitely can't support a developing fetus. Okay. So with this hypothyroidism, your patient is struggling, right? They don't have that homeostasis. So this patient, I would expect that the doctor is going to ask me to draw serum T3 and T4. I'm going to draw a TSH. In hypothyroidism, the patient's going to have a low T3, T4. Okay, and they're going to have an elevated TSH. TSH is thyroid stimulating hormone because my T3 and my T4 is low. So thyroid stimulating hormone is going to ramp up and say, hey, you guys are low. I need you to come up. So there's going to be more TSH, right? And so, of course, there's going to be the opposite when we look at hyperthyroidism. Okay, so let me say that again because it may take a moment to absorb. If your patient is having hypothyroidism, they're going to have low T3, low T4. Okay, and they're going to have an elevated TSH. Okay. Now, there is a condition that is called a myxedema coma. Do you remember the picture in your textbook? It's like the same lady in every single textbook when we look at the myxedema coma. And she just does not look very well at all. So when we, let me just bring the picture up. Oh, here's another. Okay. Oh, I think this is like the classic myxedema coma lady. Whenever they do these pictures and they like black out the eyes, I don't know if that's supposed to like you won't know who they are if you've got it. Um, their eyes black. But anyway, myxedema coma is rare, it's life-threatening. It's seen in untreated or uncontrolled hypothyroidism. The client is hypothermic, changes in mental functioning ranging from depression to unconsciousness. Severely decreased metabolism causes respiratory depression and cardiovascular collapse. Management is to provide intensive support measures along with hemodynamic therapy, and it has a high mortality rate. Okay, so this is your myxedema coma. That is an extreme, if that hypothyroidism is not controlled. Okay, and so the good thing is if a patient is hypothyroided, they have hypothyroidism, we can just give them levothyroxine, right? Or your Synthroid first thing in the morning on an empty stomach because it's best absorbed and it can cause insomnia. So we want to give it early in the morning, right? So this is your myxedema coma kind of presentation. Okay, so I think you get the idea. All right, any questions before we go to hyperthyroidism?
So what, they all just got a blank stare or just
Yes, yes. And so they've got that blank stare, that's a part of it. The thick tongue, that's another part of it as well, right? That goes with it. And so, your nursing considerations is to provide them a warm environment, right? Because they are going to be freezing, they're going to have that cold intolerance. They're going to have,
Those some look like they having a stroke though, with the whole the left sided weakness on there. They drooping on the right side. Look on the left side. Most of them lip is drooping on the left side.
well, that could just be, well, this guy, that
Left,
could be
left,
something
left.
else. But this is like the classic myxedema patient. Um, again, I just can't. And so like this whole thick tongue, that's a part of it as well. Um, this isn't the one that I usually see though. If you go to your textbook, you're gonna see one. It's like the same lady with like short hair, and it's like I've seen her in so many textbooks. But I don't see her here now, which is unfortunate, but I think you get the idea. And so also be careful when you Google stuff because sometimes when you Google a certain thing, it may not all be like, the same thing. Okay. Right. So let's see. Let's go back. Okay, so I think you get the idea though, and that generalized edema. And you're right, say when you say that blank expression, like that dull blank expression, that goes with hypothyroidism. All right, so you all know Missy Elliott, right? And if you have me for med surg, I always talk about Missy Elliott as my example. So she has a version of hyperthyroidism, which is Graves' disease, right? And so if you remember Missy from back in the day, some of you are maybe too young to remember when she first came out, but then later on, she changed a little bit, right? Her eyes started bulging out a little bit. That exophthalmos, Miss Tony is like, you remember, you
We
don't
was like,
remember?
oh, we're
I
old
definitely
enough.
remember like she's from Portsmouth.
My era.
Yeah, she.
Yes.
Say,
Okay.
Say might be a little young for the
No,
first
I'm
Missy, but
not. Well, I mean, she's a little older than I am, but I'm
yeah.
trash bag Missy Elliott days.
Okay. Can
Or
you
before the
stand the
trash bags. There was
rain?
before trash bags too.
Yes.
Can you? Okay, but so you got, so you can stand the rain. So all of that. So anyway, so when I think of hyperthyroidism, I think of her, she's come out, she's has Graves' disease, right? And so Graves' disease is the most common type of hyperthyroidism, and it causes an overstimulation of the thyroid by circulating immunoglobulins. So how does this hyperthyroid patient manifest? So think of Missy Elliott, anxiety, irritability, insomnia, fatigue. Remember, your thyroid is responsible for metabolism. So everything is ramped up now. Hypo, things were slowing down. Hyper, everything is ramping up. So tachycardia, tremors, diaphoresis, intolerance of heat, weight loss despite food intake. And Missy did lose a good considerable amount of weight over that time when she had that diagnosis.
I was going to ask
Exophthalmos.
you if that's how. I was going to ask you if you knew that's how she lost it or not. I was looking it up as you said that.
I think it may have been, excuse me, but I don't know. Like I wasn't her nurse and I'm just assuming, but I always use that as an example because like students know her if they don't know her personally, obviously, but they know her music and they kind of follow her because she's a famous figure. But I believe it was how she maybe lost the weight, or maybe she was making healthy choices, but I know that's definitely why her eyes were bulging like that. You could see the difference because at one point it was really like she had lost a lot of weight and her exophthalmos was extremely noticeable, like it was kind of distracting, right? Now, there's a couple things with exophthalmos, because that could be another kind of question that you see. When the patients had this bulging eyes, I'm really worried about their eyes being dry and then, sleeping, because they're not able to fully close their eyelids because their eyes are just, bulging. So sometimes we have to tape their eyelids shut. We might have to use artificial tears to make sure their eyes are moisturized and lubricated. So those are, genuine concerns with the patient that has hyperthyroidism. Okay, diarrhea could be possible, right? And that makes sense because on the flip side, my hypothyroidism patient had constipation. Now, a thyroid storm is a life-threatening condition. Okay, and so this is untreated or uncontrolled hyperthyroidism. So the opposite of that, remember, was the mixed edema coma. They had the blank stare, the change in the level of consciousness. They could be, it could be fatal. Now, the thyroid storm, excuse me, is the opposite. So this patient is going to have hyperpyrexia, tachycardia, hypertension, and other exaggerated symptoms of hyperthyroidism. So for your patient that has hyperthyroidism, we're going to definitely assess the vital signs. The temperature is going to be important, provide comfort. And if your patient has extreme, fever, right, hyperpyrexia, of course, we're going to be pushing fluids as long as it's not contraindicated, but cool compress on the forehead, on the neck, ice packs in the arm, under the axilla, the armpits, and in the groin. If they can tolerate it, if it's prescribed, they can even take an ice bath, but that's like for extreme cases, because sometimes that could shock the patient as well, all of that cool. So we just have to, see what is appropriate for that patient. But those are all things that we could do to get the patient's temperature down. Okay. Again, push cool fluids, rest, quiet environment, high caloric diet without extra stimulants, because we don't want to give anything like caffeine that's going to increase their metabolism even more, right? This patient is going to be weighed daily, give them emotional support, and talked about the eyes already, and we're going to elevate the head of the bed. So as far as other medications are concerned, we're going to be administering beta blockers to manage this tachycardia, the anxiety, and the tremors. We can also give iodides to decrease the vascularity and inhibit the release of thyroid hormones. Okay, and it will be given through a straw to prevent staining the teeth. So think about iodine, right? We know that it stains. Now, one of the graduates sent me this question, I think it was the day before yesterday, and I spent the day like researching and thinking about it. And the question was, if a patient is having a CT scan with contrast, are we still assessing for allergies to shellfish and iodine, right? And so Saunders says, I think, yes, still assess, but there's, I think the other graduate was using Archer. Archer said that it's a myth, that it's not related. And so I did some research and I found some sites that the doctors were saying that it's not necessarily related and we don't have allergies to iodine because it's a part of our body. And so there's a lot of different discussions. So the answer that I gave the graduate was, it's still something we still have to assess for. And the reason why is I would rather be safe than sorry, because if I do not assess for it and the patient has an allergic reaction, even though there's some schools of thought and there's medical research saying that it's not related, if they do have a reaction and I didn't assess for it, then I'm liable. And that will be negligent on my part. Okay, so in case you come across that in your studies, and I know that the textbooks and everything are still saying that, okay, that we have to assess for shellfish and iodine allergy. Okay, all right. Anyway,
I was watching
we
a
had
couple of
test
them
questions on
Archer
that.
videos too, Miss Colleen, and some of
yes,
that information that they was giving, I was like, nah, that's not what the books say. I stopped watching them.
Yeah,
Some of them was good, but some of the information they give you off Archer is incorrect. It's not
yeah.
what at least it's not what the book says. And I would prefer to have a book knowledge than, what I'm saying, any
right.
other thing. So you got to be careful with Archer, because some of the stuff that she was
Mhm.
giving out, I was like, I don't remember it saying
Yeah, and see, that's the thing, like when there's so many, and we were kind of talking about this at the beginning, there's so many different resources. You can be like going back and forth, and you could be like, a hamster in a wheel because you're like, oh, this says this. But, stick with something that works. And I like what you said, Tanya. It's like, okay, I know that Saunders is tried and true. Like when I was in nursing school,
Yes, ma'am.
Saunders, my teacher said Saunders and Hogan, like that's what she would keep saying, Saunders and Hogan, right? And so I know that, things are changing and modernizing and we have to be up with the current things, but everything that is new is not necessarily good.
Mhm.
So you do have to be careful.
And
And
yeah, and you were and um I forgot the other one. You get some bad reviews from some of the students that had it too. I feel like we don't need to go out and buy nothing else. Like we got a lot of resources other than the next gen stuff. And like some we Fortis used to do UWorld and then they
mhm,
dropped it because of some things that Fortis found that they didn't like about what UWorld was, teaching the students that
mhm,
was not really setting them up for success. So
mhm,
Fortis used to have you world about maybe a little bit before you came, Miss Colleen. We used to give
mhm.
out you world, and then we came away from it. So I say the Saunders book is tried and true, and you can't go wrong with doing them questions. And there's a lot of questions in that book.
Mhm.
Yeah,
So
I agree. I agree. And they're also depending on your learning style as well. When I was in nursing school, I really loved Kaplan. Like I love the videos. Even though they were long, I love the videos because it broke everything down. Like if you really got Kaplan, then you were good to go. So that was my favorite. And I really liked Hearst because I had the Hearst videos for content. I like Auntie Marlene. Yeah. Sarah's like, no, I do not like her.
I like her. I like her. I don't like some of the other people that do, or her colleagues or whatever. Some of them don't make it very interesting. And I just totally just would be like, oh, I was supposed to be paying attention, and I had to rewind and rewind. I'm not a fan of Hearst.
Yes.
Um, I definitely like Kaplan better.
Yeah.
Yeah,
And
Hurst
because
didn't really help us in Med Surge 1 or 2 either. Like,
I mean, I
like
get
we
it
sitting
because
there
it's
studying all
required.
this stuff, and then like we didn't do well on exams from Hurst.
Ah, but again, it's going to be up to you. And so, like, and I agree, like, get something that is,
That
what you
works.
like. Saunders
Right.
is definitely, like Tanya said, is tried and true. And you can't really, I don't think, go wrong with that. Okay, now I want to just mention one more thing with this hyperthyroidism. A lot of times, this patient will have a thyroidectomy, so the removal of the thyroid, the entire thyroid, or a partial removal. And again, we just saw that Chavasek sign and Trousseau sign. We saw that patient that has a scar on their neck. And, I don't know about you, but when I walk around, I'm like, oh, somebody has a scar on their neck. I'm like, oh man, they probably had their thyroid removed, right? It's just, you just can't help it. You look at people like, you look at people, well, I do, the cashier, like, man, she's got some really good veins. Like, I'm like, man, I could draw her blood, right? But so that's one of the things that, when you're taking these NCLEX questions as the case study is unfolding in front of you, paint a picture in your mind of what the patient looks like so it can help you, to get those clinical cues because that's what they're going to be looking for. Now, if your patient has to have their thyroid removed, we know that that's an invasive procedure. We want to think about informed consent, all those peri-operative, which includes pre-op, intra-op, then post-op. All of those things you've got to know. And of course, you're going to get baseline vitals. And I'm always concerned about airway, especially when they're having a surgery on their neck, right? That goes without saying. Okay. So, all of that is going to be really important. I'm going to jump now to the pancreas. And when I think about the pancreas, I want to talk about acute versus chronic pancreatitis, just because this is a big endocrine thing and because there's two different ways we're going to treat these patients, right? When we think about chronic pancreatitis, I'm thinking about a patient that has had pancreas issues and they're going to have it for the rest of their life. This patient is going to have enzymes sprinkled on their food because remember we said in the beginning, the pancreas is a double dipper. It's part of the endocrine system, is part of the digestive system. So this patient's going to have these enzymes sprinkled on their snacks and meals at all times, right? And we're going to look out for signs like jaundice. We're going to look out for abdominal tenderness. We're going to look out for hyperglycemia. We're going to look out for staturia, which is your fatty, frothy stools. We're going to be monitoring them, right? For scleral icterus, which is the yellowing of the whites of their eyes. We are going to also look out for jaundice. I think I said that. And this patient is going to, be monitored. We're also going to be looking out for their blood as far as, their enzymes, their pancreatic enzymes. Now, if you have a patient that has acute pancreatitis, this patient is NPO, nothing by mouth, because we know that that stomach, right, is a sack full of acid. And once there's food that gets in there, the pancreas starts working, because it's like, okay, I've got to neutralize that stomach acid, because the pancreas will put its secretions right into the first part of the small intestine, right? So that's why your pancreas patient, acute pancreatitis patient, is NPO, nothing by mouth. We want bowel rest. The patient is going to be on bed rest during the first part of the critical phase, because we don't want them to have an increased metabolic demand. If the patient has acute pancreatitis, they could have vomiting, they could have low-grade fever. And we want to look out for the Cullen sign and the Gray Turner's sign. Okay, so that's something that you should be able to know in the clinical cues. And so Cullen's sign, think of it, this picture shows you a C around the umbilicus, so that's the C. It's the bruising. The Gray Turner sign, think of it T, that's on the flanks, okay? So those are all signs that tell you this patient is a pancreatitis patient, an acute pancreatitis patient, okay? So I know we mentioned Chvosik sign, Trousseau sign, but here's some other signs that you got to know too, okay? Any questions about these signs?
I got one about the whole jaundice thing, because if I were to have a question about anything with pancreatitis, the last thing I would immediately think is jaundice, because I would think about liver if I was thinking about jaundice. So yeah, I would probably get that wrong.
Okay, well, you won't get it wrong now. So the pancreas and the liver, remember, they work together, right? They work together as part of being accessory organs in the digestive system. And so the other thing that it doesn't kind of make sense unless you know that it's true, is if a patient, and the medication that comes to mind is orlistat, if a patient is taking orlistat, they can have dark colored urine. And that tells me, yeah, kidneys too, but that tells me that they are going into liver failure, because that's one of the complications, potential complications from that medication, orlistat. So I know you can't, know everything, but that's one of the things that you should kind of know. And I'm going to ask you, do you all remember learning about orlistat and the liver and having dark tea, cola colored urine from med-surg, maybe?
Yeah, the dark urine thing is a side effect of certain even UTI medications. You will have that symptom. So
Yes, yes. And so those kind of unusual kinds of things, NCLEX can test you on that. And that could be, again, like a select all that apply, an extended select all that apply, that you would need to know that. So that's definitely true. Okay, but so you won't miss it though now. Say, right, you think of pancreatitis, you'll know, I better be looking for that as well.
oh yeah.
And that staturia, the fatty, frothy stools. Okay, I'm going to talk about metabolic syndrome, because that's going to get us to where we need to be for diabetes, and we're going to go into our DKA scenario. So metabolic syndrome, right? So because I have military experience, I think about the deadly force triangle. So I kind of like to think of metabolic syndrome as a deadly triangle, but it's actually like an X in this one. But the sides of that triangle, maybe it should be like a deadly quadrilateral. I don't know, but hyperglycemia, right? That goes with it. This patient has diabetes, also hyperlipidemia. And then hypertension. Usually this patient has abdominal obesity, and so that is a recipe for disaster, right? These things combined, this patient will have metabolic syndrome. They usually have a sedentary lifestyle. They probably smoke cigarettes, right? And so let me show you the other lady that she's like, I wonder if I have metabolic syndrome, because she is sedentary. She doesn't have proper nutrition. She has polyuria, nocturia, polydipsia, polyphagia, reoccurring infections, right? Especially those UTIs, yeast infections, vaginal infections, visual changes, the blurred vision, wound healing. We know that definitely patients with diabetes, we have to watch out for their wound healing because they're increased risk for infection, gangrene, amputation, right? The list goes on. And so a lot of teaching has to go on with this patient, right? Adequate nutrition, proper nutrition, healthy choices. Also, lifestyle changes have to be taught to this patient. Give them resources. They need to meet with a dietitian, nutritionist, so they can understand what are the appropriate things that they need to eat. Okay, and this is all, your type 2 diabetic. Now, your metabolic syndrome patient, they may have insulin resistance, and it's going to be hard for them to maintain normal glucose levels, so they may actually have to take insulin. Okay. Let's see what else. They will have to measure their blood sugars, right? Multiple times through the day, morning, noon, and night. Excuse me. Let's see what else. Long-term complications of your diabetic patient is neuropathy, right? So that numbness, tingling of the fingertips, the toes. Please never give your patients an electric blanket. Definitely don't give a diabetic an electric blanket, because they will not feel if they're getting burned. Okay, so that's your neuropathy. They can also have retinopathy. The retina can be damaged because of their uncontrolled blood sugars. Cardiovascular disease, we talked about infection, slow wound healing, right? So nursing interventions, monitor their blood glucose, administer their medication, provide education. In the chat, I put some documents that deal with blood sugar, I'm sorry, insulin, and I think endocrine kind of breakdown. So those are the documents in the chat. They may be helpful if you want to download those, and I probably will include them in the email summary that I send after this as well for the others, so they could see it. So we also want to look out for hypoglycemia, right? Because the patient be like, oh man, my blood sugar is high. Let me take a whole bunch of insulin. And so we've got to look at this. Hypoglycemia, we're concerned if the blood sugar falls below 60. If the patient is still conscious, that textbook answer is orange juice, right? If there's not orange juice, give something that is high in simple sugars, not complex sugars, but simple sugars, because the body breaks it down very quickly. Okay, so that's going to be an important thing to note. We can't give diet soda because diet soda doesn't have enough sugar, right? And so I know we don't advocate giving our patients soda, but this is a one time that, yep, I'm going to give you soda if your blood sugars are low. Okay. Let's jump into our case study, because we can then cover the things that go with DKA.
Miss Colleen,
Yes.
one of the questions I ran across too when I with type 2 diabetes, and it was asking about male patients and about your teaching, and they had said that like you're supposed to teach them that it can give them what you want to call it, male patients like soft penises,
Yes.
yeah, and
Impotence.
yeah, it was like that's part of the teaching, which I was like, oh, I didn't know. Okay, but I learned from type 2 that you got to teach the male patient about impotence.
Yes, that's an important point. So yes, I think that is a really good thing to bring up. I'm glad that you brought that up, because that's not something that I always remember.
Right. We don't talk about it.
We don't talk about Bruno, no. But yeah, so that's important. Okay, yes. So yes, and I'll leave it at that. All right, fantastic. All right, so let's go to our case study and we can have some good discussions here. I'm going to try to make it as large as I can so we can process this. Does anybody want to kind of read it out for us?
73-year-old male with a history of type 2 diabetes presented to the emergency department due to a change in mental status. At 12 o'clock, the 73-year-old male with a history of diabetes type 2 brought to the emergency department by a spouse for changes in mental status from his baseline. The client's wife reports that he woke at 6 o'clock to complete his morning routine. At approximately 11 o'clock, he became unaware of his surroundings and began sweating profusely and slurring his words. Breath sounds are clear, but noted with a fruity citrus odor and deep, rapid respirations. Sinus tachycardia per cardiac monitor. He's awake and alert, pupils equal and reactive to light. Vital signs at 12 o'clock, his temp 99.5, pulse 118, respirations 32, blood pressure 97/66, pulse ox 89 on room air, medications, I ain't attempting that, 10 milligrams by mouth daily, and metformin 50 to 1,000 milligrams by mouth daily. And okay, I'll try this. Valsartan 160 milligrams by mouth daily.
Okay, awesome. Okay, very good. Thank you, Say. All right, so what are some of the things that jump out at you before we even go to the question? Like what's
Respiration, blood pressure,
Ketoacidosis.
pulse
Fruity,
ox.
fruity citrus odor, deep rapid
Mhm.
respirations. Even sinus tachycardia would be something that I would look at, and obviously the mental change status.
Right.
Mm-hmm. Okay,
Oh.
yes, that's always scary, right? That change in level of consciousness. Okay, awesome. So I'm going to make it smaller so you can see the whole thing and try to get it in there. So which of the four findings are most significant about this patient, this 73-year-old male patient?
His history of type 2 diabetes.
Okay, so she says history.
And most significant for the situation?
Yes, so the four most
Mental
significant.
status.
Yeah, his mental
Mental
status.
status.
Also,
Mhm.
his respiration status,
Respiration.
because airway is
Yeah.
always going to be number one.
Yep.
Uh-huh. So I like what you're saying, and so we think ABCs, right?
Right.
Exactly.
And so circulation,
Okay.
Well, that's 4.
that's the four.
That's four, but is that the four you want to go with? I'm just checking them as you say them. So I just want to make sure that's the four you want to go with.
The temperature not bad. We talk about the temperature. I mean, it's bad, but is it a priority out of
It's
out
not.
of
His pulse
circulation?
ox is 89 on room air.
Right.
I
That's
don't know
typical
what 2 of those
situation.
medications are, so I would say medications for one
They're
of them,
all for
but
diabetes, though. Well, the valsartan, I don't think is,
Well,
but I know
we got to look at which one would kill the patient. So, I mean, history of type 2 diabetes, would that kill the patient? I mean,
But
yes, but
if he's doing DKA, and that's what I'm going
yeah,
with.
Right.
he's definitely, that's acidosis with that his breath. So that's why I said history. His history is important to know.
Yeah, it's important to know, though. Let's see.
Yeah.
Okay, y'all have some really excellent points. I love how y'all are kind of talking it through, right? And so you all are actually correct, right? So what the ones that you chose are correct. And so I put the rationale in the chat, and those that may be looking at the recording, because this patient has a history of type 2 diabetes, we got to follow up on these signs that tell us, hey, this diabetes is out of control. That fruity breath tells us, right? And so that is not something necessarily to follow up, but that tells me, boom, DKA. Like, okay, patients are not supposed to have fruity citrus breath combined with that respiration, which is a priority because ABCs are always a priority. And the fact that he's a diabetic tells me, okay, this is a DKA, right? It's painting that picture for me. The mental changes, that's also painting the picture. So again, these clinical cues, can you recognize based on this, the picture that's painting? So you probably, like when you were reading this, maybe you close your eyes and you imagine the patient and what he looks like. You can see the, right, those deep, rapid respirations. But the four most significant are the ones that you chose. So excellent. The history of type 2 diabetes, the respiratory status, your circulation, and the mental status. And that goes with your ABCs for sure. Okay. Any questions or comments about this? Okay, y'all did fantastic. All right, so we're going to continue. So we've got more information now. We've got more information on the nurse's note. Excuse me. And let's see. Oh, the nurse's note is the same. Vital signs
We
are
got
the
extra
same.
information on the
That's a
nursing
little bit
note.
more added to
Nursing
that
note
nursing note.
1215.
1215, he voided.
Yeah.
That's
Okay.
different.
Okay. So go ahead, Tanya, if you want to tell us what's new information,
Okay.
please.
So he voided 30 milliliters of dark amber urine, which was sent for urinalysis. Comprehensive metabolism panel, CBC, and ABGs. IV of normal saline started. 2-liter O2 sat started per nasal cannula. Capillary glucose is 440.
Okay.
So then he also got another vital signs done at 12:15. His temperature 95.5. Pulse is going down 115. Respiration is going down to 30. BP is going up, which is 98/70. Pulse op is 92% on 2-liter nasal cannula. Medication stayed the same, and now he got some lab results. So he got some ABGs, 7.20, which is outside the range. He got more ABGs, PCO2, 45, right at the range, but a little high. ABG HCO3, 32, high. Creatinine, not 1.9, high. Glucose, 435, extremely high, and other is urine positive for ketones. And potassium is 3.4, which is a little low.
Okay, so excellent, Tanya. So I want each of you to tell me something that with this lab report, this new information, what, are you thinking now? Your critical thinking, clinical judgment, what's happening with this patient? So tell us what you think.
Metabolic acidosis.
Okay, so you're thinking metabolic acidosis. Excuse me. Okay, and based on?
The pH level and the HCO3 is really high too. But it's compensated because, hold on. Yeah, it's compensated. It's partially compensated actually.
So you're partially right in what you're saying, because it is acidosis, right? Because that 7.20, right, that tells us that the patient has some kind of acidic condition, whether it's metabolic or respiratory. Okay, so that's good. Okay, so I'm going to leave it there. I'm going to go to Sarah now to continue.
You want to see what I noticed is what you're asking? I'm sorry.
Yes, to
I'm
pick it up.
following along, and I went into like in my mind metabolic, and I started doing ABGs.
Yeah, I was trying to do it in my mind. Like if I write it down, I'll be more accurate.
The two things that really got me, because I keep an eye on diabetes when I'm at my work, is the glucose and the positive ketones. Like that's the two things, like my eyeballs. Yes, I saw the obviously the ABGs, but the things that are like, I'm like right there is definitely to me the glucose and the urine being positive.
Okay. So sounds good. All right. And so since you all are working it out in your mind, I'll do it off to the side. So this is my tic-tac-toe, right? AC stands for acidic or acidosis, N is for normal, and AL is going to be alkaline. So
Okay.
the pH, what column does that go in?
Acid.
Acid.
Okay. So I'm going to put pH here, and my PCO2.
Base.
Yeah, alkaline. But well, no, it's normal range
That's
because 35 to 45. So that's normal range.
well, yeah, it's normal. It's right at the edge
PCO2
of
is
base.
normal.
Yeah, 45.
Is it going to be base or is it going to be acidic?
It's gonna be base.
No, it's the flip, isn't it? The PCO2 is flipped. Is that right?
It's gonna be
Yes,
base.
that is correct. So it's actually, so think about if the patient has more carbon dioxide, it's actually acidotic, right? Because carbon dioxide. So that's the point where I was like, okay, say you're partially right, but it is normal, but it's leaning. And I'm going to put a little arrow here when I put the PCO2 because it's leading towards respiratory acidosis.
Yeah, so
Be-
Kaplan has a video on ABGs, so you
Yeah.
know. And that's with the PCO2, you flip it. You literally just flip what the range is to
Yeah.
get it to being that. So you flip that on. I knew that was
Yeah, so that's why I was like, okay, so okay, let me I just want to share this with you. Kaplan does have a thing, but I love, and I know that many of you had med surg with me before, and I love this Nurse Labs ABG little chart. So let me just get it real quick to show you because that's how I do it. Some people like Rome, and that's okay too. But you see here in this chart, it has
Yeah.
the 45 to 35, anything to the left, right, is going to be acidic. Okay. And so it just has it flipped. So the higher number, and that's just for the PaCO2, so you don't have to worry about the Rome piece.
right.
Okay. So I'm going to put this in the chat just in case somebody wants to refer to it later. But I really love this website, and I feel like we just did this. I think it was last night or the night before. It's all becoming one thing. But I think the Med Surg 2 folks, they have an exam on this. Okay, so let's go back to our question real quick. So yes, so the PCO2 is in normal range, but it's leading toward acidic. So I just put a little arrow here. Okay, let's talk about what the bicarb is. Bicarb is
Acid. That's also acid.
so
No, that's
Oh no,
alkaline.
base.
It's
yes,
alkaline.
Too. I'm looking at the wrong thing.
exactly. And so
What is it?
that's why I was saying, say that you were on the right track to a certain extent. Okay. So
Yeah.
when you were talking about it's partially compensated, right? I would say that yes, it's trying to compensate, but
Mhm.
but this is really going to be a case of respiratory acidosis, right? Hold on, PaCO2. We're looking at acidosis, right? And so now metabolic wise, we are alkaline. Okay, we're alkaline if we do the tic-tac-toe. Does that make sense with what we know about tic-tac-toes and ABGs? Okay. Tanya, your face doesn't tell me that does that make sense or
What
no?
was it?
No, I mean, I didn't learn this so in detail as they did. I just know that once the restoration goes up, highlight that you then become, once the restoration went above the 22, you become, they getting in too much. They overcompensating. So I don't know the tic-tac-toe stuff. I'm just like, okay.
Well,
Okay,
yeah, I learned a different method too. I didn't learn the tic-tac-toe, like researching this, the simple nursing. It's called the marching band jacket method, and that's how I was doing it in my mind, and it works for me. Like it makes a
okay,
whole lot of sense.
okay, well,
No,
don't.
I understand. I like the tic-tac-toe. I like that. I mean, I'm fine with it. I like that how that worked out. I was just thinking like, when I don't know, I can't think like this broad. I was thinking just like small, like, okay, the restoration. So this is making him, I wasn't thinking in detail like that. It's good to learn it and to know that. And I'm I took a picture of it, but I
Okay.
just automatically think in my mind, okay, the restoration is high, so he's gonna be acid.
Okay, yes.
Times
So
that it'll be fully compensated as if the pH is normal. That'll be
exactly,
fully compensated. If
exactly.
the other two are like teeter-tottering, it's partial. So if one is acid but one is base, that's partial. And if they're both just like getting along with one another, it's uncompensated. That's how I kind of with
Mhm.
the marching band jacket method like that I learned.
Okay, and that's good. And I really didn't want to go down this road, but I had to kind of, just because
Yeah.
when you were mentioning it, I was like, part of it is correct, but part of it is not correct.
Mhm.
So I just wanted to mention it. So if it confused anybody, I'm so sorry. But
No, no confusion. I never get, I'm LPN, so they never went into that much details about it. It just, do you see that the number is high? Okay, so now you need to remember that this is respiratory. If you see the number is too low, just remember that. So
Yeah.
okay.
my learning was a little simpler than this. They have to know a lot more. RNs have to know a lot more, and I'm learning that. But the LPN is just simple. It's
Okay.
high, low is low.
She said it's
Yes.
simple.
Okay, but that may also help you if you have a question. And so that can help someone, because I'm going to be honest with you, I never really understood ABGs in nursing
Yeah.
school. I started to understand it when I became an instructor, and I realized, like, I really got to study this before. How could I explain it to my class if I don't have any idea? I just prayed I wouldn't get an NCLEX question, and if I did, I would just guess correctly. So, but the Rome I never really liked, but this tic-tac-toe works for me. But if you've got a marching band, if you got voices in your head, whatever works, that's totally great. Whatever, whatever
I got
works for
some of
you.
both.
We don't
It's
talk
hard
about
to do it in
burnout, and
my
we don't
mind
talk
though.
about the voices in my head. We don't talk
Yeah.
about that.
It's really
Okay.
hard to do it in my mind though. Like I gotta really like do the method like to get it accurate. But like, trying to just look at it and do it, like I have a hard time still.
Yeah, so that's why I just wanted to show you the tic-tac-toe method just in case.
Yeah.
And who knows that you may have a question like that. I don't know, but at least you're kind of familiar. And I put the link. It's Nurse Labs. It's a really good website. I really like it. Nurse Sarah also has ABG tic-tac-toes. And for LPNs, I don't necessarily think you have to go into that level of detail. But the next time you go back to school for your next degree, right, you will. Okay, so just so you know. All right, so the nurse starts an IV and reviews the labs. For each finding, click and specify if it's consistent with ketoacidosis or HHS, hyperglycemic hyperosmolar syndrome. Each finding may support more than one condition, and each column must have at least one correct choice. Okay, so the first one, the pH, is that consistent with
Can I do the
ketoacidosis?
can I put a check for urine? I know that one.
Okay, sure.
Keto.
Urine is
Yes,
keto
thank you.
because
Ugh.
it's positive for ketone. Okay, good job. That is correct. Excuse me. Okay, pH.
The pH is acidic, so I would say acidosis. I mean, it would make sense. They're both acidic.
Okay, and you are correct. Blood glucose.
The glucose hyperglycemic
Yeah,
osmolar.
I'm put over there in the glucose.
Yeah,
Yeah.
because it's
Yep,
high.
right over. Mm-hmm.
Okay,
The
what about
creatinine,
for ketoacidosis, blood glucose?
Can we do both?
I would say yeah.
Yeah, both.
You
Yeah,
can do
both.
both. Okay,
Okay, I
yeah.
didn't know that. Okay.
If you
Uh,
And
creatinine.
creatinine.
That's kidneys, right?
Creatinine is high. So
I would say
Sam,
I would say acidosis for creatinine.
Okay, you said acidosis for creatinine.
Well, what is it,
Okay.
Gio? You all up in my computer screen.
Okay. So,
I'm not sure about creatinine.
okay. So for ketoacidosis, all of these should be selected, right? So
Yay.
that part is correct. Okay. And so let me also put,
Yes. Is the
yeah,
serum creatine for both or no?
it is, and it's
Oh,
not the blood glucose for HHS. Okay,
Okay.
so I put in the chat the rationale, and I'll just say it aloud for anybody who's watching, right? So serum blood glucose in DKA can fluctuate between 300 and 800. It's typically though above 600 with HHS, okay? So that's something to remember for HHS, right? It's usually above 600. Low pH and urine ketones are seen in DKA. That is the name, diabetic ketoacidosis. We've got ketones in the urine, and those values, the pH and the ketones, are typically normal in HHS, and both conditions can cause dehydration, and that's going to give you your elevated creatinine, and that's why they both wait a minute, conditions cause dehydration and elevated creatinine. Okay, so and the urine being particularly dark is particular to ketoacidosis. Okay. Any questions about that?
Okay, so we had it kind of backwards. We chose the blood glucose for HHS instead of for the creatinine for both.
Do you have any
Yes.
information on the HHS syndrome you can send me? Because I know about it, but not as clearly as I would like to.
I agree.
Yes.
Yeah,
I
yeah,
was stumped by that.
yeah,
Um,
that'll be cool.
I'm gonna put it into the chat right now. I have a flow chart on HHS. And this handout calls it HHNS. Okay.
Okay.
And okay, it's in the chat. So let me just pause for a second just to talk about HHS for just a moment. So it's hyperglycemic, hyperosmolar state. It's an acute, life-threatening complication of diabetes. And I'm just going to mute you for a second. Is characterized by elevated blood glucose levels greater than 600 mLs per deciliter. Okay, it's a hyperosmolar state, which leads to fluid and electrolyte losses. So what are the contributing factors to HHS? Acute illness, right? So it could be surgery, infection, stroke, medications that exacerbate hyperglycemia, such as your thiazides, right? Your thiazide diuretics. Treatments such as dialysis can also be contributing factors to HHS, and you should see the handout also in the chat. Medications. Well, we're going to look for signs of dehydration, and that makes sense with that serum creatinine, right? That tells us that the patient is dehydrated. In HHS, the patient will also exhibit signs of hypotension and tachycardia and an elevated BUN. Okay, and HHS is generally not seen with ketosis. Now, the patient can have an altered mental status with HHS. So your nursing interventions for HHS is to replace fluids as prescribed, but we want to monitor for fluid overload, and we want to administer insulin and electrolytes as prescribed, which makes sense if the patient has a blood sugar of 600 or higher. We want to monitor the blood glucose, levels of consciousness, the vital signs, electrolyte levels, acid-base balance, and teach strategies on how to prevent HHS. Okay, so that's a little bit with HHS. I feel like we don't really necessarily talk about it a lot, but this question, if you knew about HHS and DKA, you would definitely get the pieces right. And I'm going to, in the summary email that I send, I'm going to send some more resources on HHS because I think that would be helpful. Okay, let's go to the next question. Question 3. What has changed? The nurse's notes are the same. The vital signs are the same. The lab report is the same. So we're going to complete the sentence from the list of drop down. The problem the nurse should first address is correcting the pH, restoring volume, or lowering the glucose. What do
Lowering the
you?
glucose. Lower the glucose.
Okay, so she says lowering the glucose. Does anybody say anything else?
I'm gonna go with it.
So that's important, but also that blood pressure is really low too. And the pulse is up. So would the volume be important?
Yes, the volume is actually what's
The
the
most
most
important.
important. Yes, so the priority is to restore the volume so that they can get adequate perfusion. Now, the thing with your patient that has DKA, they're really like super dehydrated. Like that's one of the things that go with it. So that's why they're, they're getting IV insulin and we're checking their insulin, their glucose levels every hour, but we also have to rehydrate them. And then when we force this rehydration on the opposite end, now we have to monitor their potassium levels. So, and we may end up having to give them potassium. Like it's kind of weird how that treatment works, but like that is going to be the priority to rehydrate them and then to give the insulin to bring that sugar down. But the rehydration is key so they can get proper perfusion. Okay. All right. Any questions about that?
So
And
keto is pretty much severe dehydration, pretty much.
it's severe dehydration, but it's coupled with that elevated blood sugar, right? So, but the dehydration is so severe to the point that they don't have enough blood to go through their veins, if you think about it like that. Okay.
Makes sense.
Yeah, and I'll definitely send you some more because I think that DKA is a huge thing to definitely get your arms around. And I think if you feel comfortable with it, then if you see it, you won't have any issues on the NCLEX. Okay, so question 4, let's see. The nurse's notes are the same, the vital signs are the same, meds are the same, the lab reports the same, right? So the client is diagnosed with ketoacidosis and the nurse begins to plan care. For each nursing intervention, click to specify whether the intervention is indicated, contraindicated, or non-essential. Okay, so you all tell me, obtain A1C, excuse me, is that indicated, contraindicated, excuse me, or non-essential at this time?
I don't think obtaining cholesterol would.
No, the
A1C
A1C.
is your
Yeah,
sugar.
it's sugar.
It's important.
None.
Do I feel like it's
I heard non.
A1C is cholesterol, right?
no, it is not, ma'am.
No,
It
that's
is
sugar.
sugar, honey.
Glycosylated
Oh,
hemoglobin A1C. Yes.
That's over the 3-month test, to see if they've
Right, how
been
the
doing
sugar's
right.
been.
Well, at this
Mhm.
point, it's not really essential because we already
We
know
know
what
what
something
sugar
is.
That's important.
Okay, so you're saying non-essential. Okay, fine. What
It's
about
important. It's not right then,
right, because we're in a crisis situation, right?
Right.
Yeah.
Okay, so yes, and you're thinking correctly because okay, this patient is not stable. We got to get this patient stabilized. What is the most important? Okay, so teach the client pursed lip breathing.
For what?
You see my
Okay.
face?
So think about what so this
Just
is a
Well, so
respiratory
he won't
question.
Yeah.
Oh, the
So-
respiration
Yeah.
start.
Yeah, it's high,
that's
right? So I'm
indicated.
like, yeah,
Yes.
maybe to get him to look, calm down, to breathe, to get out.
Okay.
That's
I know
indicated.
your facial
Indicated.
expression is funny.
Yeah.
So okay, so think about it. Would this help the patient? Like, so this is kind of
Yeah.
like one of those, would it help the patient if I do this right now? Okay.
Yeah.
And
Slow his
so
breathing down.
okay, yeah. So you're saying that it's indicated. Okay, very good. Administer insulin, glargine, subcutaneous.
I would
Would
say
he be on a
yeah.
drip?
They already on a drip dose. I mean,
No, or would he be on a drip? Did it say he was on one? That's my question.
Okay, so let me ask you this. Is this patient that has DKA, how do we treat it? Are we giving them sub-Q medications or are we giving
No.
IV insulin?
IV
give it
directly into
IV.
that line.
Okay, so,
Not indicated then.
or is it indicated,
It's
contraindicated?
contraindicated because
Contra-
he's already getting. It's contraindicated because they're already getting insulin.
Okay,
Because they'll check his sugar every hour and then they'll adjust that insulin as needed
Uh-huh.
if he's
Okay.
in DKA.
okay.
Inserting dwelling Foley catheter,
I
non-essential.
don't care for it.
He's
so.
peeing.
It doesn't say if he was not
Right.
awake,
No tension, no nothing.
Right.
Yeah.
Okay,
It doesn't
Yeah.
say
so you're saying indicated, contraindicated, or non-essential.
contra,
Okay,
not, yeah, contraindicated. Well,
I
or
don't think
not
it's important.
essential.
Me either.
It's
It's
not
not essential.
contraindicated, but it's not essential.
okay,
But
so indicated means yes, we got to do it. Contraindicated means it could harm the patient. Non-essential
you,
means it's
It's
something you
not
can
important.
do, but not
right,
important.
not they'll say
Yeah, it's
non-essential.
non-essential.
But in a hospital setting, that is contraindicated. They don't, so I don't know
Oh,
if that's gonna be, because that's invasive. And if the patient's awake and can go to the bathroom, wouldn't that be contraindicated?
mm,
I just don't
Okay,
think it's important for
okay.
right now.
okay,
Am I
okay.
wrong?
So now something to look at
Makes sense to
is,
me, Sarah.
okay, so you all have great discussion points, and I'm not trying to sway you either way, but one of your strategies you can look at is, okay, what's going on with the patient's urinary status? Is this this Foley catheter going to help, or is it going to
No,
hurt?
he voided 30
Yeah,
milliliters
yeah,
dark
and
amber
doing it
urine.
wrong.
Okay,
So he within the hour of doing the right thing, giving out the right input, the right amount, even though he's dry. I don't know if
mm-hmm.
it's contraindicated or non-essential. I'm not for sure.
You know,
I
it's
just
not
don't think it's
indicated.
important right now.
Right.
Okay, so I'll leave it as that because I know it seems like you all are torn between contraindicated and non-essential. Is that true?
Right. That is true.
Okay, excuse me. Okay, IV potassium.
Hmm.
I thought you said that was indicated because you said
Yeah,
once we give him the fluids, we're gonna have to check his potassium.
yeah, it's only
We're gonna
got
check it
4
again.
anyway on the thing, right? Ain't it
Okay, well, let's
4?
go look at the lab
Yeah,
values.
So
it's
that's
a
all
little low.
5.1. It would, I'm gonna read into it too much, so y'all make the decision.
Okay,
I'm gonna
well,
say it's indicated 'cause it's a little low, and then they're getting a lot of fluids now at this point. So
Okay.
okay, so indicated.
Yeah.
Okay, monitor EKG.
yes,
It is
because
definitely
we're
Indicated.
indicated.
administering potassium. So yeah,
Potassium.
Okay, that was good. Y'all are like, of course, it's potassium. She keeps telling us about potassium. If she tell me about potassium one more
Exactly.
time.
We gotta monitor the EKG.
Okay, all right.
You
So
should have a monitor on anyway.
you all did pretty good. Okay, so let's talk about it. The hemoglobin, glycosylated hemoglobin A1C. You all said that that's the test that's done every 3 months. We don't need to do that now. We already know that the patient's blood
Oh.
sugar is over 400. That is non-essential right now. 3 months from now, they can go and get their A1C, right? Done. But right now, we got a real-time blood sugar. We know the patient is in crisis. So it is non-essential. Teaching the patient personal breathing, it is indicated this patient needs to calm their breathing down. They've got deep, rapid respirations. We need to have them do that per slip breathing for sure. Okay. Um, Administer insulin glargine subcutaneous. No, this patient is on IV insulin. Okay. We're not going to be giving them subcutaneous. Okay. Whenever you have a patient that is in crisis, like in this case, they're getting IV insulin. If you have a patient that is a cardiac patient, is on a cardizem drip, you're not going to give them cardizem by mouth. They have an IV that's going. Okay, this is a critical patient. This is an ICU level kind of patient right now, right? Or an ICU step down kind of patient. Indwelling Foley catheter. It is contraindicated. There's no reason that this patient should have this Foley catheter. That's just going to increase their risk for infection. We already know that when we just talked about metabolic syndrome and diabetes, that they're at high risk for infections. We talked about the yeast infections, right? And the patient has 30 mLs of urine in an hour. We don't like the way the urine looks, but at least they've got some urine, okay? So it is contraindicated. And yes, the IV potassium, I kind of gave that answer to you, not on purpose, but that is the way that we treat our patients with the DKA, the hydration, the potassium. We're giving IV insulin, monitoring their blood sugar every hour, right? And of course, potassium. I was like biting my nails because I was like, they better give this patient potassium. Whenever your patient's potassium is low, you must replace it. Potassium needs to be within 3.5 to 5.0 because it's critical for the heart functioning, right? So whenever a patient has a potassium of 3.4, don't second guess yourself. You have to do the potassium replacement, and then you're going to reassess to draw the blood again to see did the potassium improve, because you may have to re-administer potassium again. So don't hesitate to replace your patient's potassium, especially in this kind of scenario. Any questions about this? And of course, we're monitoring the heart for sure. All right, question 5. The nurse's notes are the same. Vital signs the same. Medications the same. Labs the same. But we've got doctor's orders now that we didn't have before. Okay, who wants to read that?
Admit to the ICU with a diagnosis of ketoacidosis. Give 1,000 mils of IV normal saline, fluid bolus over 30 minutes. The start of normal saline with 20 MEQs of shoot, I'm about to cuss. 100 mils of that at 125 mils per hour. Start regular insulin infusion at 0.1 units, 0.1 units kilograms per hour after fluid bolus. A finger stick blood glucose hourly. Titrate insulin infusion based on ICU protocol. Obtain electrolytes every 2 hours and continuous cardiac monitoring.
Okay, so there's a lot going on with this patient, right? And we kind of knew that. So there's a lot. So let's talk about what should the nurse do. The nurse reviews the orders, and thank you, Say, for reading that. What action should the nurse take while implementing the treatment plan? Okay, select all that apply. Let's go one by one. Begin insulin after bolus at 0.9 units per hour.
What action? What info? I mean, yeah.
So it says
Okay.
the start of 0.9 normal saline. Does that mean then start? Is that the order right there? Or does that, because I would ask doctor for clarification. It says the start 0.9 normal saline.
I think it should be then start.
Okay, then that explains,
then
yes, we
start
begin.
Yeah, begin the insulin after bolus. 0.9 units per hour. I would choose that.
Okay, so
Hold on. Yeah, after bolus. Start regular infusion after bolus. So yes, begin insulin after bolus.
Mm-hmm.
Says it right there. Start regular insulin infusion.
And all those fluids, I would definitely monitor for symptoms of fluid overload.
okay, so you're going to give insulin, and what else are you going to do?
The very last one.
Monitor for symptoms of fluid overload. Okay.
Hold on, I didn't read the other ones. Hold on. Not the third one. We're not giving him sugar.
Right.
Once the client does status does stabilize, then we do let them eat. Once because they are NPO when they're on that insulin drip. And I was thinking about that earlier, asking you about that in the NCLEX world, but you are NPO if you're on an insulin drip. You can have ice typically and water maybe, but you don't get food. At least
you admit don't normally get food or drink for a while, right?
You know, it depends on where you. So in ICU, you're right, but like regular floors, they get food usually, unless they got
Admit to
something like testing.
ICU with diagnosis of ketoacidosis.
Like I said, normally that situation, no, because they're the DKA. That's what I'm saying. They do not eat until they're in their insulin. You know, until they get it back off that insulin drip and they're doing regular insulin. So when they're on that, when they're in the hospital at the hospital,
I would just pick the last two. I don't know
wouldn't
about the
give
rest of
them-
it. I would allow the client to eat when status state. Yes, because you eating is good with insulin. That's what I've been taught. I mean, I don't know ICU level, but eating is good. You know
Right,
what
when
I'm
it
saying?
stabilizes. The answer is yes.
Yeah.
Yes, so the answer is yes because it stabilizes. Yes.
You just went to ICU. You would get them stable before allowing them to.
Yeah, but it says allow clients to eat when status stabilizes.
It says stable. Yeah, when it's stable.
Okay.
That's what I would pick.
Yeah, we're not going to hold insulin. That's silly.
Okay.
Right.
All right. So great discussion. So let's take a look at this. Okay. So begin insulin after bolus at 0.9 units per hour. Well, the doctor's order says start regular insulin
Right.
infusion at 0.1 units.
Right. I was not picking that one. I just said
Yes.
last suit. No, ma'am.
Yes,
I know.
so that is not correct because we are giving, and that 0.9 was meant to trick you because it's the normal saline. We're going to bolus 1,000 mLs of
Right.
normal saline over 30 minutes, right? Because remember, we got to rehydrate the patient. That is like the priority here, okay? Then we're going to start 0.9 normal saline, and that should be 0.9 with 20 milliequivalents of potassium chloride. So now we're giving the potassium because the potassium was low. And this is typically, I feel like I didn't do a good job giving you the recipe for treating DKA. And so I'll definitely follow up in the email with like a step-by-step or a really good video of what happens with your patient. So the bolus of fluids, and then it says start the normal saline with 20 milliequivalents because we know that we can't push potassium fast, right? I know, Tonya, you're not going to be doing IV push, but this is, you know, you're going on. I can see you
Where
as
is the
a
potassium?
doctor.
Where did you see?
So,
Where does it say potassium?
The third
Which one
So-
of them?
bullet point.
let me annotate it.
Okay.
So this right here,
Oh,
20
that's potassium.
milliequivalents. Yes, potassium is the
Okay.
K and the Cl is chloride.
Thank you.
You're
Okay.
welcome. So that's telling us that, okay, start regular insulin infusion at 0.9 units per kilogram per hour after the fluid bolus. So 0.9 was meant to trick you, okay? Finger stick glucose hourly, right? We know that's a part of the glucose, the glucomander protocol. We're going to check their blood sugar. Titrate insulin infusion based on the ICU protocol. What does that mean? And I know I said glucomander, but that's what I learned it as in Centera. If your patient is on an insulin drip, right, like, you know, cortisone drip, which is cardiac, but insulin, every hour we are going to take their blood sugar. And once we get their blood sugar,
Adjust.
you're going to change it. Exactly. You're going to adjust it. That's what titrating it means. Obtain electrolytes every 2 hours because we are giving so much, right? Fluid at this
Right.
point. Cardiac monitoring. Okay. So anticipate holding insulin for low potassium levels. Yes, that is true. Okay. Because, and I'm not going to do a good job explaining the biophysiology, what's happening at the molecular level, but when your patient has low potassium, you're going to hold that insulin because, again, we're concerned about the heart functioning. So that's, we kind of have to hold the insulin if it's really low. And so we're going to, it says insulin therapy is typically held if levels fall below 3.3. So if right now the patient has a potassium of 3.4, so we're going to
Right.
continue with the treatment because the problem is not only if the potassium gets too low, now we're concerned about their heart, okay,
Right.
and them going into cardiac dysrhythmia. And that's something we don't want to add to the complications for this patient, if that makes sense.
So that's saying keep an eye out. If it gets too low, then you're going to stop the insulin. Is
Yes,
what
you
that's
can,
saying.
yes, anticipate holding the insulin,
I
okay?
gotcha.
So request IV fluids with dextrose when glucose levels start to normalize. So I know you're like, well, they had DKA. Why would I do that? The problem is, and that's why they're on this insulin drip, we're trying to gradually bring their blood sugars down, but we could bring it way down, right? Too fast. So if it's to the point where the patient is now hypoglycemic, we're going to have to give them fluids with the dextrose to bring their blood sugar back up. That's why this is an ICU kind of scenario, because this patient's blood sugar can go from 600 to 50, right? They're not stable. Okay, so that's another reason why we have to check their blood sugar every hour. Okay. Okay, so that was a tricky one. Okay, and so allow the client to eat when the status stabilizes. Tonya was adamant about that, and it is correct,
Oh.
right? So once their respiratory status is stable, yes, they can eat. I'm not going to give them, 10 sugary, Krispy Kreme donuts, right? But they're going to be able to eat something. And of course, monitor for symptoms of fluid overload is correct. Okay, is going to be correct. So this was a tough one, but this one tells you, okay, if you're not sure of the exact treatment plan for treating DKA, this is something we've got to review a little more closely. Okay. All right. The last part of the question. Okay. So we got new notes here. Who hasn't had a turn or who wants to read the new notes?
I got you. Transfer 1230, transfer to ICU. IV fluid bolus given. 1300 started on maintenance IV fluid and insulin drip. 1330 capillary glucose 435. Awake, alert, oriented to person in place, taking in full complete, talking in full complete sentence, denies pain, breath sounds are clear, void. 300 milliliter clear color urine. So the vital signs as of 1330 was 98, pulse 105, respiration 30, blood pressure 100/70, and pulse ox was 94% on 2 liters nasal cannula. 1330, I don't know why they gave it to us twice. I guess they took it again.
Yeah,
At
they got
1330.
95 on liters now. Yeah, the blood pressure's up a little bit.
I
The
think it's
But
supposed
you
to.
see it says 1330 twice.
I know. I'm thinking that's supposed to be 2 o'clock. Anyway, we keep
Okay,
going.
let's try
I
2 o'clock.
Oh wait a minute.
98.9. Yeah.
What?
Doubling back to that last question, wasn't giving them that bolus was not the right answer.
What do you mean
Because it
giving?
was like insulin and
It
it
was
said
talking about the insulin.
0.9.
Yes.
It
Yeah.
was like 0.9 something of
It was talking about
The
it wasn't the
insulin.
Yeah.
right stuff.
The
It was the
insulin
insulin
was,
at
that would have been
0.9
too much.
because
Right.
it was like 0.1, not 0.9 or 0.4.
Yes.
a bolus of insulin. That's what it said.
You do that
No,
when you're
No.
no.
it was a
But that's
bolus of normal saline of
Well,
1,000
it says at
mLs.
12:30 transferred ICU IV fluid bolus given. Like we chose that one on the last question, but it wasn't the right answer.
No,
Nah.
you chose bolus of insulin at 0.9. But it was
Oh, it said insulin.
0.1. Yeah.
Okay.
yeah, so insulin. Yeah.
So it's late. I'll give it to you, but that could be the difference
It's
between a
somebody.
right or wrong answer. So make sure you're
Yeah.
reading carefully. Okay. All right. Go ahead, Tonya. So there's a typo in the time. So we'll just say that that's after, that.
Okay.
Quarter after 13:45.
Let's
Yeah,
say,
that's
okay,
fine.
so 13, so the temperature is 98.9, pulse is 100, respiration is 24, blood pressure is 109/70, pulse ox is 95% on 2 liter nasal cannula. Medicine stays the same, ranges stay the same, lab values stay the same, order.
God bless you.
They got continued cardiac monitoring. That's about the only difference.
Yeah, everything's the same on that. Yeah.
Everything else is the same.
Okay, so I like these questions. So the nurse reassesses, and thank you for that, Tanya. The nurse reassesses the client after giving a fluid bolus and starting the insulin infusion. Which findings indicate the treatment plan has been effective?
Blood pressure.
Blood pressure got better.
Okay, and I'm gonna try to see
If I remember at the beginning, they said something about the person's mental status was, I don't know, I don't remember reading nothing about the mental status, but their mental status was all messed up in the beginning.
Before they came in.
Okay, so what is it now?
Oh, they're awake, alert, and oriented, time, place,
Time.
talking. Yeah, mental status. You can check that one.
Okay, absolutely. I'll check it for you. Okay. What else?
Their
Can you roll
pulse
back
is
up to
slowly
the
going down.
pulse? I think the pulse
Yes.
is lower.
Yeah, the pulse is at 100 now.
Exactly. That's better.
Okay, so you want me to check pulse?
Yeah.
Mhm.
Uh-huh.
That glucose is not
You
Yeah,
don't like the glucose?
It's only down by 5 points. And so to me, I
Okay.
mean, it's still got some work to do. I mean, obviously it's not going up, which is good, but it's not,
Yeah.
it's not
Okay.
saying it.
Okay.
You know about
But
no
then
pain
again,
levels
I
and like
mean,
that. I think we all right with where we at.
yeah.
Okay, and so you're correct. Okay, so here's the rationale in the chat. So when we think about treating DKA, we're managing, correcting serum glucose. We're, talking about the dehydration. And in this case, right, dehydration was the key. We have to get proper perfusion. We get the insulin drip going. We also want to address the electrolyte imbalance, particularly the potassium. We're also addressing the acidosis. IV fluids are going to be given, infusion of insulin is going to be given. We have to get those ketones out of the body. So that's why we're flushing the body as well. Okay, and that's going to correct that acidotic state. And then we're going to end the production of ketones from the fat breakdown. We reverse that ketone production and we correct the fluid electrolyte imbalance, right? And so this patient now will have a normal blood pressure because their blood pressure is increasing. The heart rate is going to decrease, right? And then the cells are going to become rehydrated. Glucose is going to move into the cells, and that's going to help the patient's level of consciousness. Their neurological status is going to improve. They're no longer going to be confused. And pain was not even an issue with this patient in the first place, right? And breath
Right.
sounds were clear. He just had deep and rapid respirations. Okay. And Sarah was 100% correct. She was like, I don't like that blood glucose. Like that is only moved 5 and it's still in the 400s. Like that's not good.
Right.
Okay. That is not good. Okay, that is the end of this case study. I'm going to stop and I'm going to kind of go around and I'm going to make some notes because I feel like we have just scratched the surface. I don't feel like we have fully mastered that. I have given you information to fully master the treatment of DKA. Um, I think more work needs to be done on that. I'm going to give you some more resources. Let's go check in with Say real quick.
Yeah, I mean, I'm all right with it, but I'm not 100% confident about that topic. Yeah, I kind of slipped up in a lot of places with that one.
Okay, fair enough. Fair enough. I think I might have to do a deep research and do a better video on DKA based on that. All right. What do you think, Tanya? What do you think about this scenario and session?
Yeah, I think I've learned it. I'm constantly learning, so I think I can wing it. I know that they say don't pick nothing that you don't. If you're not for sure, I'm not gonna pick it. I'm just gonna pick what I know is for sure, because at least I'll get some points. I'd rather
Yeah.
gain points than not to have points. And so I'm not, if
Yeah.
I'm just not at that where I'm gonna keep guessing and thinking about it. If I don't know it and it didn't ting on me, I'm not picking it.
Okay, and
And I just
that's
say
good.
read the questions well. Gotta make sure we paying attention to our questions, and that's it.
For sure. Okay, thank you, ladies. Okay, Sarah, what do you say?
I knew a lot of it just because I work at the hospital, and that's a lot of I knew the answers. The ones I didn't know about was different things that we, I guess, don't concentrate in our ICU. Maybe they do, and I just don't know either because I haven't been the nurse. But I would love to have more hey, here's some 10 questions about DKA. Go try them out and see if I got the mastery of them. That would be awesome. And
Okay,
I can look that up
awesome.
obviously too, but if you're gonna look it up and you find some really good questions that oh, these are really good NCLEX style questions, that would be good. That way I can kind of okay, these are my answers. Did I get them all right? Or you tell me, hey, these are the answers and why they're right. And then I can look over them because I look at your daily questions and I look at them in the morning. I tell my mind what I want the answer to be and I recheck when you put the answer up there.
Okay, sounds good. And I think I'm gonna also
You
crack
can
my
click
books
on
open.
hers. You know that, right? You ain't gotta wait for Miss Colleen to post it. If you click on it, it takes you to the site and give you the right answer. Yeah.
Sometimes when I put if it's
Oh.
retrieved from, sometimes I
Oh,
where it's from.
oh,
I'll say,
okay.
hold on now. No.
But sometimes it do. I just click the answer. It takes me to the site. It tells me if I'm right or wrong. I mean, even though she's gonna tell us, but just click it and
Right.
see if it takes you.
Yeah.
It makes me think about it though, I mean, I'm weird. I think about it the whole day.
Oh,
Because I think of myself, okay, I'm at my hospital on this floor and this is what I'm doing.
mhm.
I learned that from a lot of Kaplan, other places said that as well. You put yourself you're in there with that patient. You imagine yourself there. And so I
Yes.
get a lot of that. I'm like, okay, I would do this or that and a third.
I
Okay.
think I got today's question wrong. When in my mind
We're gonna
anyway.
start recording.